Hello and thank you for having me. My name is Dr. Sophie Wickham and I wanted to talk about the importance of policy in the psychological impact of poverty. So I really wanted to give you a bit of a whirlwind tour of some of the work that I'm doing on poverty and mental health and the impact of some policy changes on some of these things. So to start with, I wanted to talk about mental health inequalities. So mental health inequalities are differences in health status or in the distribution of health resources between different populations arising from social conditions in which people are born, grow, live and work. They are unfair and they are avoidable and could be reduced by the right mix of government policies, which I hope I will go on to demonstrate. So we are in a mental health crisis in the UK even before the pandemic. So what this image on the left here shows is the large mental health inequalities we are seeing across England. This is a composite annual measure of population mental health for each lower super output area in England, and it combines data on mental health from multiple sources, such as NHS, mental health related hospital attendances, prescription data for antidepressants, and things like incapacity benefits and employment support allowance for mental illness. It combines these into a single index, and then you can see here the geographical spread of mental health. Thus, mental health inequalities across England and Liverpool, where I work, we can see worse mental health in comparison to other areas in England. And in fact, in 2019, there were 20,000 more people living with a mental health difficulty compared to the rest of England in Liverpool. There were also over 30,000 children living in poverty in Liverpool. That's 1,000 more than the year before and 6,000, more than 5 years ago. And what I'm interested in what causes these differences in mental health. The drivers of many mental health inequalities are structural. They're due to inequalities in the main influences on health, as outlined by this Whitehead rainbow, which identify the social determinants of health. This neatly maps the relationship between the individual, their environment, and health. Individuals are placed at the centre, and surrounding them are various layers of influences on health. To be clear, the drivers of inequalities are down to differences in poverty, differences in power and resources that are needed for good health, differences in exposure to health-damaging environments, and differences in opportunities to enjoy positive health factors and protective conditions that maintain a healthy life. And these are all driven by policy. So to focus on child poverty now, we have seen a rise in child poverty since 2010, reversing a longer-term trend of falling poverty. All 4 official measures of child poverty show large increases in the number of children living in households below the median income, the 60% median income before and after housing costs. Child poverty contributes to a large, persistent and widening inequality in the UK. So if we look at things like life and death, a child born in the most deprived 10% of areas in the UK can expect to live 10 fewer years than a child born in the most deprived 10% of areas. This rises to 20 years if we think of life lived in good health. Pre-pandemic numbers suggest that 4.2 million children are living in poverty. That's 30% of all children. And I think what is key to understand, especially in the policy context, is that work does not provide a guaranteed route out of poverty, with over 70% of children living in households where at least one person is working. There's a substantial body of scientific evidence, some of which we have already seen, which links child poverty to poor outcomes, so poorer educational, physical and psychosocial outcomes during childhood and across later stages of life. Early life exposure to poverty and other significant adversities impact not only on the developing brain, but also other organs and the immune system. And collectively, these developmental disruptions leave a child more susceptible to physical and psychosocial stresses as they get older, undermining their mental and physical health through adolescence and into adulthood. What this flow diagram represents is a simplified example of how household poverty influences child health and development, leading to negative impacts across the life course. Some key findings from research within our team at Liverpool make it clear that there is a toxic and wide-ranging effect of experiencing poverty as a child. And as one example, I'm going to look at the mental health effect of poverty. So we see this time and time again in an analysis of the UK Millennium Cohort Study, which is a large nationally representative study of children born in the millennium and followed up every few years, and it's still going on. We examined whether or not moving into poverty during a child's life is relevant for children's and mothers' mental health, independent of parental employment status. We focused on children who were not living in poverty and looked at the impact of any changes over time in their household income. After accounting for other factors that might influence mental health, we found that the odds of poor mental health and well-being in children were significantly increased if they transitioned into poverty during their childhood. And the same was true for the mental health of mothers of children in the study. And again, this was independent of parental employment status. Using the same data, we found that by age 14, more than half of those children that had been in poverty at some point over the study period, and 1/5 of the children had lived in poverty their whole lives. Holding all other things equal, persistent poverty tripled children's likelihood of having mental health problems in adolescence, and it doubled their likelihood of other health outcomes. In addition, children who experienced poverty for only part of their childhood also had worse health outcomes on average than children who had never experienced poverty. So why is poverty rising? Really, this is down to the cost of austerity measures, a fiscal policy designed to reduce government spending, primarily through the welfare system. And while fiscally successful at reducing spending, some implemented welfare policies have had direct consequences for poverty and mental health, which have been heavily criticised. So in more recent years, we have seen, well, last year, we have seen that the Joseph Rowntree Foundation report suggested that removing aspects of universal credit, which is a new welfare benefit, which I'll go on to talk about, removing a temporary uplift of £20 a week will push another 70,000 people into poverty. So this has really been the policy response to poverty. Policymakers are often concerned that increasing access to benefit disincentivises employment, and they see that employment as the route out of poverty. And as I've shown before, employment, we have seen the impact of poverty independent of employment status. And in fact, we have seen big changes to the welfare system since 2010. So in 2013, we saw the introduction of universal credit, which is a flagship reform designed to maximise claimants' responsibility and reflect a working lifestyle if your working structure is being paid monthly in arrears. So in 2013, at the same time as universal credit, we saw the introduction of the bedroom tax, the abolition of discretionary social funds, the introduction of personal independence payments. We saw a benefit cap. Then in 2015, benefit freeze, and in 2017, the introduction of the two-child policy, which has drastic implications for bigger families. The introduction of universal credit has been heavily criticised, with anecdotal evidence from general practitioners on the mental health toll of the new benefit system and how it has been implemented. Qualitative findings suggest that the implementation of universal credit has driven people into debt, rent arrears, increasing stress, and in some cases, people thought about committing suicide. And you may have seen in the news recently, people have committed suicide and they have identified universal credit as one of the primary causes. Just before the pandemic, I published some work looking at the introduction of universal credit and its impact on employment and people that were unemployed. And we found that the introduction of universal credit led to an additional 7% of unemployed people experiencing worse mental health. That's an additional 64,000 people experiencing psychological distress between 2013 and 2018 as a result of this policy introduction. Now, of that, it has the potential to mean that 21,000 additional people developed psychological distress that reached clinical levels of depression. And again, universal credit had no impact on employment. So given that over half of families in the UK receive some type of state support, it's really important to consider how these policies are impacting on poverty and mental health. And even those that seem to have small individual effects can have major implications for population health. So what do? We need to ensure that all policies are maximising mental health benefits and minimising mental health harms, and not just mental health, all health. We need to act early, act on time, and act together. And this is not something new. This has been found time and time again in all of these reports. There is no point having a policy system that is moving people into employment if it's also causing mental health distress. Welfare reform that is generating mental health problems is unlikely to be cost saving if it's pushing people into other services and health and social care. From a health perspective, it's so important to ensure that the benefit entitlement is adequate to live a healthy life. And this includes reducing uncertainty around the benefit assessment, implementation, and delivery. A benefit system that respects those claimings, respects their individual needs and potential need for future flexibility. Basically, we need to put health and health equity at the heart of welfare policy. There are some concrete things that central government can do, such as putting mental health in all policies, so looking at the cumulative impact assessment of any future changes to any policy, but particularly welfare policy. We need to be investing in the early years and recognise that child poverty and what is going on with children is a key time point in future health outcomes. If employment is going to be a route out of poverty, we need to introduce a true living wage that reflects this. We need to be from a local level, from an NHS perspective, we need to advocate for vulnerable groups and allocate resources to reduce mental health inequalities over the life course. We should be pooling resources with other partners to ensure that there is universal support for early child development that is developed and maintained. I think the message is clear. We need a whole systems approach for a welfare system to work on those facing adversities. We need to act early, we need to act on time, and we need to act together. Thank you very much.